Greetings from London. My name is Dr. Bahadoran. I'm a consultant neuropsychiatrist and liaison psychiatrist at Princess Royal Hospital in Sussex, UK. Thanks for the opportunity to discuss and share the results of this study, which was done with a number of colleagues at the departments of neurology and neuropsychiatry at St. George's Hospital and the so-called Regional Neurosciences Hub based in Southwest London a few years ago. And sorry for not being able to deliver this yesterday. It was due to a last-minute change, which I was still thinking that's going to be in the afternoon. Anyhow, so I need to share my do you have the
no, still we don't have your
what about now?
presentation. No, not yet.
Yes.
Not
Yes.
yeah, now we can see your screen, doctor.
Sorry. Yeah. Okay. So the results were published in Neurological Sciences summer of last year. Here's a list of my colleagues and co-workers. So the subject of depression in movement disorders has been of particular interest over the last 2 decades because of the diagnostic uncertainties and complexities in diagnosing this, and also because of the multifactorial etiology of depression across various movement disorders, in particular the Parkinson's spectrum, which apart from the chronicity and debilitating nature of Parkinson's is also due to its direct effect on the brain. So generally speaking, depression is the most common, or one of the most common across all of these the disorders, one of the most common non-motor or neuropsychiatric symptoms to various extents. In Parkinson's disease, it represents the commonest non-motor disturbance, according to all the studies which have been done so far, followed by anxiety. And it's broadly known to be caused by involvement of the neurotransmitter systems, including the dopaminergic, norepinephrinergic, and the serotonergic system, and in particular the limbic, dopaminergic, and norepinephrinergic system, the base of the brain. Interestingly, it can be seen at any stages, many years, even prior to the onset of the motor manifestations of Parkinson's and related Parkinson's spectrum conditions, or in early during its course. It is known to have to indicate more rapid deterioration in overall functioning, most importantly in terms of cognition and motor functions, and a very marked negative impact both on the quality of life as well as on engagement with treatment and compliance with medication. Of note of the fact is that despite all these, in various studies which have been done, there's not many of them, but the ones which I had access to, it has been undiagnosed in up to 50% of cases. For various reasons, the complexity of the symptoms, a huge amount of overlap between, for instance, the psychomotor retardation caused by the illness itself, by its direct effect on the base of centers in the base of the brain, anhedonia, etc., as well as the fact that this is usually done by neurologist colleagues working in very busy movement disorders, specialist clinics, or general neurology clinics, with very limited time to check for the symptoms of depression. So this kind of prompted us to look for a number of rapid, or if you like, one could say ultra rapid scales, which could be of some use for our neurologist colleagues. So long as we can remember this is not to diagnose depression, it's just meant to flag it up and refer the patient through their GP to the relevant services, or when possible, like in the case of our study, to the Department of Neuropsychiatry or related psychiatric services for further assessment and clarifying the existence of the lack of depression in these patients, and hence early treatment and so forth. So just a quick look at the prevalence with regard to Parkinson's disease. We have various figures. I've summarized the most recent ones, as you can see, based on the DSM-4 criteria. At the time, they were classed in 3 different groups: dysthymia, minor depression, roughly speaking, corresponding to mild depression under ICD-10, and major depression, more or less equivalent to moderate and severe depression under ICD-10. We used the lower figures, which were more consistent with our sample, and excluding inpatients and people in nursing homes, and for instance, people with Parkinson's and other types of movement disorders, dementia. So basically, more like population-based studies. You can see the prevalence across a handful of other known conditions, which highlights again the importance of a quick screening in the movement disorders clinic. The standard measures used traditionally for assessment of depression in Parkinson, you can see the list here, including the famous HAM-D and the SCID under DSM, as well as the MADRS. Particularly a favorite has been the Unified Parkinson's Disease Rating Scale, or MDS-UPDRS, which is widely used by various Parkinson's and movement disorders clinic. The items 1 to 1 to 1 to 5, 1 to 1 to 1 to 5 is a questionnaire. The geriatric scale, depression scale, has been used, especially in the elderly. Both the 15 and the 30 item, but the 15 one is particularly favored. And the last 2, the 21 item Beck Depression Inventory Fast Screen, or BDIFS, and hospital anxiety and depression have been actually validated in more recent years on both sides of the Atlantic, in America and in Britain, and another number of other English-speaking countries, as well as I think in Japan and some other European countries. So these are all valid questionnaires and very popular and used a lot in various settings. However, the main snag is that they take a lot of time. And so no neurologist can be expected to sort of go through all of these questions with their patients in a limited time that they have for seeing their patients. So hence the need for a more rapid screening tool or tools. The study, as I mentioned earlier, was done at St. George's Hospital Regional Neurosciences Hub back in 2016 and 17 on 200 consecutive outpatients with either established or putative diagnosis of movement disorders. And the measures or the questions were completed while they were waiting to be seen in the waiting room, and include a basic brief demographic questionnaire and a questionnaire asking about the duration and the perceived severity to compare with some of the individual items that we come to briefly. We use the MDI as our reference or standard, and we tested 3 different scales: hospital anxiety and depression scale, which I mentioned earlier, ET or emotional thermometer, and NDDI, which is used for the assessment of depression in the epilepsy population to see if it has more or less similar utility in this field. So the exclusion criteria you can see here, we did not process the incomplete questionnaires unless it was just 1 or 2 items. And the first questionnaire is the only one which we process if in the case of patients who handed more than 2, more than 1, and of course in the case of patients who were unable to understand the questions well or couldn't consent in a clear, unequivocal way, they were excluded from the study. So MDI, as mentioned earlier, has been used to generate diagnosis of ICD-10 depression, but later adapted to DSM with some minor modifications. We use this as our gold standard to compare our findings against, and the sensitivity, specificity, and positive and negative predictive values were collected and compared to test the accuracy of our tools, as well as some indicators of diagnostic utility, including the fraction correct, the Udens J statistic, and the positive and negative utility indices. We use standard published diagnostic cutoff values for each tool, but looked into our results to see if we could suggest alternative cutoff points for some of the tools. A quick look at the MDI. It's basically a 10-item self-report questionnaires assessing the severity of the symptoms within the last 2 weeks on a scale of 0 to 5, and it uses a somewhat different number of criteria for assessment, for diagnosis of depression under the 2 classification systems, ICD-10 and DSM-4. The hospital depression anxiety happens to be very popular in England and in the UK. It was developed back in the 1980s, and it's broadly used across various liaison settings in Britain, as well as various outpatient clinics. So it consists of 2 scales, HATS-D and HATS-A for the depression and anxiety respectively, and the combined scores can also be pulled to generate the HATS-T total score. Altogether, there are 14 items and relatively easy to answer, including for those patients who, in which English is not necessarily their mother tongue. It's scored between 0 to 3, with 8 to 9 indicating borderline, and more than 10 suggesting definitive diagnosis, with a reasonable high sensitivity and specificity, as you can see. The emotional thermometer was originally suggested as a new so-called visual analog scale, which doesn't need clinician scoring and checking and rechecking back in the early 2000s by Alex Mitchell and co-workers. And in 2017, they published a new version, the 7-item tool. So the initial one consisted of measures of distress, anxiety, depression, and anger. So we're just looking at that, we could rate it on a visual analog scale. And basically the 4-item one takes about a minute, the 7-item one about 7 minutes, and it doesn't need clinician scoring, as I mentioned earlier. It's been used broadly in the field of cancer and standardized in some settings, as well as other fields, diabetes, nephrology patients and so forth, and most specifically cardiovascular patients. And in the last several years, in particular, there's been an interest to use it in neurological patient populations, including 2 studies which are also done at St. George's Hospital by my colleagues in the field of epilepsy and multiple sclerosis, broadly speaking, generating quite similar, very similar results. So last is the NDDIE, Neurological Disorders Depression Inventory for Epilepsy, which has been used in over the last decades increasingly and actually standardized in some settings. It's a 6-item, easy to answer questionnaire, consists taking 2 minutes or slightly over 2 minutes for the most psychomotor retarded patients, with just a tiny bit of assistance, if at all. And it has a high sensitivity and specificity of 81% and 90% respectively, for a cutoff of 15 out of 24, which is also the one that we use in our study. The sample, as I said, initially considered 200, and 188 were included. You can see the age distribution very broad, between 21 to 93%, 50.5% were male, and here's the ethnic makeup of the sample. The diagnoses as well can be seen in this table. They were mostly patients with Parkinson's disease, although we didn't include this bit in our study. But by the time the study was finished, a good 30 to 40 of these were diagnosed with alternative conditions or the other conditions in the Parkinson's spectrum or types of mixed dementia. So the age of onset was likewise very varied, and the duration of symptoms basically varied from 6 months to 44 years. Interestingly, we had the same prevalence for depression in our sample using both classificatory systems. That's 25 individuals, or 13.3%, which compares, but it's definitely lower than the 17% figure that we mentioned earlier. And again, it was interesting that 22% fulfilled both criteria. Sadly, you could see that even in a tertiary referral center in London, with lots of academic links, and only 20.9% of the patients were on antidepressants, and 6.4%, which is a very weak figure, were receiving any psychological therapies, with only 5% receiving both. And I haven't mentioned this here, but unfortunately, most of these were done through the primary routes, that is, through their GP. Only a handful of them were in contact with secondary mental health services, which again underscores the importance of further diagnosis of depression in these patients. Here we can see the receiver operation curves for both sets of symptoms, very similar, as you can see, and generating very similar results, and on the basis of which we handpicked the 5 tools and their the individual items for further analysis and discussion. And these 5, according to the receiver operation curve, area under the curve, were HATS-D, Hospital Anxiety Depression Scale, had the largest under ICD-10. The same results we found with regard to DSM, but with a different sequence. Of note was the fact that the single item depression thermometer, one of those 7 colored so-called thermometers, which I just demonstrated, was found to have a potential use as a single ruling, if you like, ultra rapid screening, definitely not like the diagnostic value. So very similar across both systems. With regard to the standard performance indicators, such as specificity, sensitivity, positive and negative predictive value, HATS had basically identical performance under both systems, with HATS-D having a reasonably high 8.84 and 0.74 for sensitivity and specificity, respectively. On the whole, it was found to be a highly accurate and of great utility. And the results also tallied with an earlier study done back in 2006 and 2007, looking into the usefulness of this scale in the movement disorders, in particular Parkinson's patient, with a cutoff of 9 to 10 and 11 to 12 for the respective categories, but of course using Hamilton. NDDI was also interestingly found out to be of good diagnostic screening, not diagnostic, sorry, value under the DSM-4 major depression criteria, with a sensitivity of 0.8 and a specificity of 0.81. So as I mentioned earlier, this is used, has been actually standardized in some settings for the diagnosis and rapid screening of depression in epilepsy patients. So emotions thermometer, interestingly, was again very similar in terms of both classificatory systems, ET4 and ET7, the 4-item and the 7-item, taking 1 and 2 minutes respectively. They compared very closely, actually identical under ICD-10, although under DSM-4, ET7, the 7-item one, was clearly more advantageous in terms of sensitivity. Again, it was interesting that both depression and anxiety thermometers, these are the individual items under the ET, emotional thermometer, otherwise known as E2 and E3, were found to have of some screening value. So in particular under the DSM-4 major depression criteria, with a sensitivity of 0.86 and 0.82 respectively, suggesting a possible usefulness for these two indices in the sort of ultra rapid, if you like, ruling in or ruling out of depression with just one question. So obviously, again, I need to reiterate the purpose is not the diagnosis of depression. This needs to be done by a qualified person and a different setting, but just to highlight this by our neurology colleagues and sort of define the roadmap and the way forward. So in conclusion, all four of these scales had comparable overall performance and rather high. And some of the previous results are also replicated. And we can recommend use of all these for both in terms of clinical and more specifically for future research in samples with a greater number of movement disorders patients, maybe multi-center studies. Would be very open to the idea if any colleagues are interested, as well as the fact that HATS and NDDI both perform very, very well, but with the main snag remaining, that is, they require clinician scoring and double checking. Hence, we're thinking of something like 10 minutes plus, which is not a very popular idea in a very busy neurological clinic, especially in a movement disorders clinic with limited resources. So emotions thermometer, they do not require scoring. They're highly subjective, of course. They have the potential to rule out depression if it falls below the cutoff score of around 3, or suggest further exploration for depression if it's above that. We have been able to demonstrate that. We suggest a cutoff of equal or greater than 13. It takes less time to complete than ET7, 1 minute, with almost similar performance. With the added finding that both depression and anxiety thermometers, the two tiny colored ones, can be used as a potential single measure to rule in or rule out depression, again, needless to emphasize, at a screening level. So in other words, they have the potential utility to be used alongside any of the scales that I already mentioned, as well as other potential scales, other scales being used in the field. Thank you very much for your attention, and would be pleased to answer any questions if there are.